a medical trainee and medical registrar at the moment. I hope you can all hear me properly. So today we're going to be doing the third part of the OSCE series on abdominal examinations. We've already covered cardiology and respiratory exams in the previous sessions, so hopefully this will just be an extra added step for you all. I'm going to hopefully get you to put comments and questions in the chat, so I'm really open to that as we go along, because we don't really have any questions as we normally do for our SBAs. So the aim really, I've just got one aim, and that when you leave this session, you're just a bit more confident in performing an abdominal examination. And obviously as a medical registrar, it's going to be mostly from a medical point of view as opposed to a surgical point of view, but I'll try to incorporate both themes in this session. So we're going to review each step involved in an abdominal examination, and we are also going to provide, just going to move my camera a bit, provide my top tips as we go along the way, and we're going to review 2 cases at the end just to bring it all together. So the abdominal examination is it's special because you can actually have a wide range of cases that can come up in your examination. So you can get hepatology cases or liver cases, you can get IBD, renal, hematological malignancies, obviously surgical cases. So when I was doing med school, our OSCEs were divided into medical and surgical OSCEs. I don't know if that's the same for most of you, but we also had surgical OSCEs where we examined the abdomen. And then you can get ad hoc cases such as HHT, PJS, and acromegaly. And that's because they all have a bit of a GI component to them. So for example, HHT, I don't know if anyone is able to comment, put a comment in and just say if they know any links between HHT and any GI pathology. That would be amazing. Although I wonder if I can see the comments in the webinar. Probably not, actually. I just realized that. So we'll just leave that, but just think about it. So just think about the fact that the abdominal examination isn't just going to be a liver or an IBD or a renal case. You might just get something different and you'll just have to put it all together. Great. A written appropriate position is important, and that's because position is everything. So initially you're going to start your patient at 45 degrees and then lay them down supine at 90 degrees. This is very important, and I'm going to emphasize that later on as we go along. But that's just 2 things I want you to remember. So like with every other presentation so far, you start with washing your hands and then you don your PPE, which is different now. So most times you'll have gloves plus or minus a plastic apron. You'll introduce yourself to the patient. So your full name, who you are, what you do, and then you'll ask the patient what their name is and their date of birth. You can also ask them what they'd like to be called. And then you'll explain to them what you're going to do. So I'm going to perform an abdominal examination. This will involve examining your hands, your neck, your face, and also then I will feel your abdomen, your stomach actually, and listen as well. So you'll just have to learn what's comfortable for you, so that when you get into the exam, you can just say that straight out. So I used to just practice them actually, so that when I got in there, it was just straight out of my mouth without actually thinking about it. And then of course you're going to obtain consent from the patient. Is that okay? And you want them to say yes. And then you move on to the position. So first off, you want them at 45 degrees at the start. So you're looking straight at you, 45 degrees, and then exposure is important. Of course, it's the abdominal examination. So usually if it's a man, I just ask them if they can remove their shirt at this point. If it's a woman, they're usually wearing like a tank top or something. So usually that's enough just for this moment. And then later on, obviously, we will then ask them to expose their shirts further for the abdominal part of the examination. Right, so this is my routine that I use. I've written make it your own just because sometimes it differs for different people, but this is what I do. So initially you're going to start off with inspection. Then I go to your hands, forearms and arms, then face, neck. After the neck, I actually go to the back, and after the back, then I can lie them down, and then abdomen, and then legs. So it just goes, and that's because that's the same format used for my cardio and rest stations. So then it's just natural. Anytime I go into my stations, I know I'm just going to do that, and then modified for each examination. but obviously, like I said, just kind of do what you think works for you. So inspection. So from the end of the bed, I look at the patient. Obviously, I know it's an abdominal examination, so I'm going to look for GI signs. So you look at the body habitus, high BMI, low BMI, are they cachectic? I look at your arms, your face, looking for any signs of any jaundice, hyperpigmentation. If your abdomen is exposed at that point, I look at for scars, any abdominal distension, stomas, drains, anything at all. Medic alert bracelets for anyone who's like on long-term steroids, and feeding tubes such as NG tubes, NJ tubes, and just really just have a very good look, and also make it look like you're looking. So really look at the patient, and then you will then look at the environment itself. So you're looking for shoes, and they don't hide them, but they don't make them very obvious. So you really have to go look at the table, what's on the table. Can you see any glucose meters? Sometimes they have the forticips or the nutritional supplements there. And then you can have insulin pumps as well. Just there, again, that will be on the patient, obviously, but let's just be aware that you will just, again, like every examination, just try and build up clues as you go along. They say that by the time you reach the abdomen, you really want to know what the patient, you should have a good idea of what the patient might have, even before you've actually felt the abdomen. That's what they say. So try and just kind of build up clues as you go along. Okay, so we're going to go to the nails, hands, and arms. So again, I don't think this can be interactive, unfortunately, but it is all good. So just try and think about what you would expect with the, I do apologize, sorry. Let me see if I can just put my thing on do not disturb, hopefully that works. So on the looking at the patient's nails for a GI examination, so you want to be thinking of three things that I put down. So leukonychia, koilonychia, and clubbing. I'm not going to really focus on clubbing just because I know you've done that in your previous OSCE series. But we've just got examples here. So this is koilonychia, or spoon-shaped nails. You see that iron deficiency, anemia. Then you've got leukonychia as well. So you see that with low albumin states, such as chronic liver disease, or inflammatory bowel disease. And of course, this is how you get the patient to find this is how you investigate for clubbing. So you ask the patients with their index fingers together, and you're just looking at this window to see whether or not you lose this window, indicating that they might have clubbing then. So it's really important that before you get into your examination, you know the causes of all three, particularly clubbing. They will ask it, they always ask it, they will definitely ask it if a patient has clubbing. Why do you think this patient has clubbing? And obviously when you see clubbing in a GI case, you want to start to put that together again. This is another clue that will hopefully help you to decide what the likely diagnosis is in this case. So obviously with GI cases, causes include inflammatory bowel disease or chronic liver disease. So it's really important to actually know all these three signs that you see in nails. Right, so you go to your palms then. So I've put, again, you want to know the causes of all, like palmar erythema, again, in a GI case, so things like chronic liver disease as well would cause you palmar erythema. I put acromegaly here, and that's because you can also see some signs. Obviously, they have large spade-like hands that they say, in acromegaly. And acromegaly is an example of a disease. Oh, you can get questions and answers. Oh, great. Acromegaly is a disease that can manifest with colonic cancer, hence you might get it in a GI case. So obviously if you have a patient with sweaty palms, large hands, finger prick markings indicating diabetes, you might think, wow, this patient has got acromegaly. So you just start to kind of put the clues together. They might get some pallor of the palmar creases and getting some anemia, Dupuytren's contracture, hyperpigmented palmar creases that you would see in cases such as Addison's. Okay. Someone said, can I have a copy of the meeting that's recorded, please? I think the meeting is going to go up on YouTube, so you'll be able to rewatch it as much as you wish. So we've just got an example of palmar erythema here as discussed. And again, we've just got these two hands, obviously no acromegaly and patient with acromegaly. It's just to kind of indicate that the hands are actually a vital source of clues for you. Okay, so then you've ask the patient, obviously, can I look at your hands? You look at the nails, the hands, you felt them to make sure they're nice and warm. You turn them over to look at the palmar, look at the palms, checking for palmar edema, etc., and all the things we've talked about. Then I would check their pulse at this point, and I check the pulse for every patient, whether or not it's a cardio arrest or abduction. So these are just examples of why you might check the pulse. So if they're tachycardic, if they're bleeding, for example, or if they've got tumors such as a FAO, they could be more tachycardic. And obviously in bradycardia, you can get patients who are bradycardic who are on beta blockers. The next question would be, what patients in a GI case would be on beta blockers? Just have a think for 2 seconds. Why would a patient be on a beta blocker? And I'll then say it. So that's 2 seconds. So one example would be a patient with chronic liver disease with evidence of esophageal varices. They tend to be put on beta blockers to prevent any hemorrhage, and it basically just reduces the pressure in the portal systemic system. And obviously they've got portal hypertension, which is exacerbating their varices. So you give them beta blockers, and it just reduces the pressure in the splanchnic distribution. Okay, so then I've checked your pulse. So next up, I'm going to check for asterixis. So this is a PLAB. It's not a tremor. So you obviously it's a sign of either CO2 retention, uremic encephalopathy, or hepatic encephalopathy. Obviously, the last two are relevant in an abdominal examination. Obviously, with uremia, you might get that in chronic kidney disease, and hepatic encephalopathy in chronic liver disease. So I just really liked this illustration, which I found on Twitter. And it just shows that it's a brain malfunction as a result of increased ammonia in the blood. Things that we used to treat patients with hepatic encephalopathy include lactulose in the first instance. And if they have a second episode, we give them an antibiotic called rifaximin. And then apparently hypokalemia increases your renal ammoniagenesis, which can worsen HE. So I think that's quite nice. So hopefully you'll remember the treatment, and never forget to check asterixis in your rest station and in your abdo station. Excellent. So you've done that. Then at this point, you're going to offer to measure the blood pressure. They'll probably say, no, that's great, carry on, and then you carry on. A reason why you might measure the blood pressure would be for partial hypertension Addison's, for example. So next up, we'll go to the forearm and the arm. At this point, there are many signs that you can pick up in a GI exam, so please look carefully. Again, if anyone wants to shout out anything in the chats for what you would look for at this point, please do. But I've got examples. So things that I would look for, AV fistulas, I'd look for them in the wrists and also in the elbows or the ACF. We'll talk a little bit more about AV fistulas or arteriovenous fistulas. I'd look for tattoos and needle track markings, which you might find with chronic liver disease as evidence of possible causes for having hepatitis. Excoriations, which you might see in patients with primary biliary cirrhosis, and bruising, which you might see with patients with issues with their anticoagulation, such as in chronic liver disease. If their INR is high or they have low platelets, they're more likely to have bruising around their forearm. So just keep a really close eye just on your forearm and your arms in your GI exam. It doesn't seem like it'd be that important, but you could really, really miss out on a diagnosis just by not looking at their arms. So this is just, I just have two examples of two different fistulas. So they might look like this, or they might look like that, but generally you won't miss them. They're quite massive and very obvious on the patient's arms. So the first thing I would do is I'd look at the side. So it's radiocephalic, i.e. at the wrist, or brachiocephalic, or brachiobasilic actually, just by the elbow creases. I'd look for signs of inflammation, looking for erythema or any swelling. And then I'd look for visible needle marks. Now that's really important because it indicates that the patient's still using their fistula or they've recently used it, which tells you this patient needs renal replacement therapy. And obviously this is important if subsequently you find out that this patient also has a transplanted kidney. So if you've got a patient with a transplanted kidney who's also having a fistula that's working. It tells you this patient's kidney is probably not working and this patient needs renal replacement such as dialysis. So just for anyone who might know, so we use AV fistulas as access points for patients who are in hemodialysis. It's seen as the optimal choice for patients because apparently it lasts longer and there's less complications than you would see in patients who have other ways, other systems for their dialysis. So there are many ways a patient can access dialysis. So there's an AV fistula, you can have tunnel blinds, and you can have peritoneal dialysis. But AV fistulas are usually the most common and the most likely to be on your examination, just because there's a lot of things that you can do with them and you can talk about them a lot. So when you've looked at them, then you're going to feel, it's going to feel like a thrill. It's not a pulse, it's a thrill. It's going to feel just like a little thrill when you palpate. And then you listen for a bruit as well. It sounds like any other bruit that you'd expect. So it's really important to do all three things. And if you haven't, I'd suggest just going to a renal department or a renal ward, and you'll definitely find patients with fistula, and just do everything just to kind of get familiar with the three parts of the examination. Again, if you have any questions, please put it in the chat. Okay, so then we've looked at their hands, their forearms and their arms, and we're happy. So we're going to go to the face then. So it's just good to have a look quickly just to see if there's any evidence of any systemic conditions. It looks like I'm obsessed with acromegaly, but it's just a really obvious one to look out for in your examination. Then we go to the eyes. So you can find a lot of things in the eyes, especially in the GI examination. So we've got scleral icterus here as evidence of jaundice, and we've got a nice example of case of Fletcher rings, which you can see in Wilson's disease. Other things that I could look for: conjunctival pallor, which we examine also in other exams, such as the cardiovascular exam, and xanthelasma, which you might see in primary biliary cirrhosis as well. Okay, so the eyes are like with every examination, you're going to do that. You're going to ask them to lower their lower eyelids down, and you'll have a look. Then I would then go obviously to the lips and mouth. This is obviously important in a GI setting because there's so many things that you might find. So you can get oral ulcers with inflammatory bowel disease, angular stomatitis, you can get hyperpigmentation of mucous membranes in cases such as Addison's, you can get pigmented macules in PJS, or Peutz-Jeghers syndrome. Telangiectasia of HHT, as we discussed earlier, these are cases that may present in a GI examination, and that's just simply because with PJS they can get GI bleeding, because they've got these hematomas in the GI system that can cause that are benign, but they might also develop colonic malignancies. And then with HHT or Osler-Weber-Rendu, they get this telangiectasia or AV malformations in the GI system as well, which can, these don't bleed, apologies. These can cause polyps and possibly malignancies, and these bleed because they've got telangiectasia or AV malformations in the GI system. So this is why these two might be on your GI examination. And, you know, they do come up. I know a colleague of mine who said she got this in her examination at Cambridge. So they do come up, and it's worth knowing if you don't know about them and just learning about them. You can look at the tongue, then leukophocalocytis in vitamin B12 deficiency, and macroglossia, which you can find in acromegaly. And then gum hypertrophy is a complication of cephalosporin, which we use in immunosuppression in renal transplants and also in liver transplants actually sometimes. Great. So these are some of the macules that you might see in PJS and examples of telangiectasia that you might see in HHT. So you've done the face, you've done the eyes, you've done the mouth. So sorry guys, I know that's really annoying. So you go to your neck next. So I always look at your JVP, one, because I do that in every other examination and I just do it automatically, but also it's useful, obviously, if you're looking for evidence of fluid overload, particularly in chronic renal disease, and you might just indicate that this patient's got evidence of fluid overload as a result of a kidney that's not working. Then after I've checked their JVP, I ask the patient to sit forward, and that's because I'm going to then check their lymph nodes. This is important because one, as I've written here, you might get a node in the left supraclavicular fossa, which is Verka's node, or Trusser's sign, which is where you, which is an indication of a possible GI malignancy. But it's also important because you can get hematological malignancies in your GI cases because they tend to present with splenomegaly, which is a brilliant sign. So you definitely want to check your lymph nodes just to make sure there's no palpable lymph nodes. So you're finished with the neck. So the patient's sitting forward at this point, and then I think it's a really, really good time to move to the back. So you tell them to lean forward. In the back, I just look everywhere for everything and anything that might help my case. But usually the most common things you'd find would be spider nevi. So if you have more than 5, it's usually pathological. You want to palpate, or palpate the spider nevi and just check that it fills from the center and then out, which is classical. So it's going to, when you touch it, it's going to disappear and then it will fill in from the center and then out. You look for scars, and these are really important, particularly with renal cases, because they tend to have posterior scars. So you can get from a nephrectomy scar. You can also get scars from nephrostomy tubes as well that have been inserted in patients as well. So you finish with the back. At this point, hopefully you're having a general idea of what your patient may or may not have. And then you go back to the front. So they were at 45 degrees, you're sitting down. I would position them at 90 degrees at this point. And then I've written inspect again, just because it's very important that you haven't missed anything. So at this point, you definitely want to be able to see their upper chest. So you just ask them if they haven't, if they might be able to either, I don't know, unbutton their shirt or just remove it if possible. Obviously, you keep your bras on if it's a woman. So at this point, I'm also still looking for spider nevi, gynecomastia, which you might see in patients with chronic liver disease, and also scars from tunneled lines. So this is an example of another way to dialyze a patient. So we've talked about AV fistulas, and now we'll look for scars. They're usually here. And we can use tunnel lines in, let's say, so it takes 4 to 6 weeks, for example, for a patient after you've created your AV fistula to actually use it. So you can never just immediately use an AV fistula. So sometimes you can have a tunnel line in the interim, and it enables the patient to have dialysis while waiting for the fistula to form. Sometimes patients don't like fistulas, actually. They would rather have a line instead. So sometimes it can be just an option. Sometimes patients just have very bad arteries and veins that we just, veins that we can't actually use them for fistula. So then we're stuck with tunneled lines. So there's a myriad of reasons why a patient would have a tunneled line for dialysis. So it's really, really good to kind of just look for evidence of any scars from previous tunnel lines, and that will give you a clue as to what the patient may have. You look at for other abdominal scars, so things like incisions. So we've got the Mercedes-Benz scar from a liver transplant, cholecystectomy, laparotomy scar, a Land scar for appendicectomy, phalansteal scar, and then of course the Rutherford-Morrison scar, which is pretty, it's one to know for your renal transplant patients. This could also be there, obviously. Other scars could be one here from a liver biopsy. It's actually worth looking at the necks as well. Sometimes they have transjugular scars as well for a transjugular biopsy. And then this is just a picture of a peritoneal dialysis catheter. So sometimes they might have a catheter, or sometimes they might just have a scar from that. So again, you mightn't know what the scar is, but you can kind of come up with a possible diagnosis. So you might say this could indicate a previous PD catheter. It could indicate a scar from a previous acidic drain. It could be a scar from a liver biopsy. It's great if you have an idea of what it is, but hopefully when you've got hints from other, so if the patient's obviously got a fistula here, but I think the most important thing is that you don't ignore the scars, or just really, really look for the scars, especially because these renal transplant scars can be actually quite low down. So sometimes patients, you need to really expose the patient down to at least their hip bones, just to kind of make sure you can really look lower down and not miss any important scars. And sometimes if a patient's got a high BMI, you might have to actually lift If you've got a lot of skin folds, for example, you need to lift the skin folds so you don't miss any scars underneath. So you really, really need to look, or else you might miss the entire diagnosis. So other things I would look for in inspection, any obvious abdominal distension, the classic 5 Fs, caput medusa, which are distorted veins over the abdomen, which usually present in portal hypertension. You might get striae in the abdomen, which could indicate steroid use. What patients require steroids in GI cases. So patients with inflammatory bowel disease, sometimes patients with transplant, so renal transplant, liver transplant, they usually may be on long-term steroids. Then you look for any obvious masses or visible masses at that point, any stomas. Don't just bypass the stoma, have a good look at the stoma, look at the contents, try and visualize what kind of stoma it is and the output. Is there a spout? Are there two, is it just one, oh my gosh, what's the word I'm looking for? I've forgotten the word I'm looking for, I do apologize. But just really examine your stomas and don't just ignore them, because again, it's really important to kind of build up a picture of what your patient has. You might ask the patient to raise their head a little bit, because then that might make any obvious hernias or any masses a bit more visible for you. Okay. So you've inspected the patient, you have a clear idea of what they have or do not have, and then you're going to palpate in the 9 quadrants. So you usually do superficial palpation first. Again, it's a good time to ask the patient if there's any pain or any tenderness, just to make sure that you're really checking. And then while palpating, you want to look at the patient's face. I know we all focus on the stomach at this point, but it's really important while palpating to look at the face. And then you go for deep palpation as seen here. When you do come across a mass, stop. Examine it properly, checking for the size, the location, consistency. Is it mobile? Is it tender? And then just depending on where the mass is, you might then have an idea of what it could be. So obviously, like we talked about, if there's a mass here and there's an overlying scar, you might then think, oh, this could be a renal transplant, a kidney transplant, or it could be a mass if it's here from inflammatory bowel disease, for example. And then once you've palpated the abdomen, then you have to palpate all 4. So liver, spleen, kidneys, abdominal, aorta. So next up, we've got the liver. So you want to put the edge of the hand right, starting from the right iliac fossa. You want to go down as much as you can, just so you don't miss a large liver. And asking the patient to take a deep breath in. While they take a deep breath in, you move up, and then you're just examining to see. The point is as you move up, you're checking to see if the liver falls down. So when you take a deep breath in, your liver should actually fall down, just because the chest wall expands, and as the chest wall expands down, the diaphragm flattens. So the diaphragm flattens, your liver comes down. So if it's a large liver, hopefully when they take a deep breath in, it should just hit your hand just here. So you keep doing it every 1 centimeter. They take a deep breath in, check if it touches your hand. It doesn't. No, when they take it out, you move up, in, out, in, out. Okay. So once you've done that, you repeat the same movements for the spleen. Again, you're starting from the right iliac fossa, exactly where you started in the with the liver, and that's because a large spleen doesn't actually just extend inferiorly, it tends to extend diagonally. So you want to start from the right iliac fossa to the left, moving upwards, again on inspiration. If you still don't feel the spleen, at this point, you're going to tell the patient to roll over towards you, putting your hand underneath the costal margin and putting your left hand behind. You're going to palpate to see if the spleen, or you can feel the spleen edge. So it's just another maneuver to ensure that you cannot feel the spleen, and then you get them to lie back down. So at this point, you really want to be aware of the causes of hepatomegaly, splenomegaly, and hepatosplenomegaly. There are numerous causes of each of them, and it's really something that you cannot go into your GI exam without knowing. So just learn them. I'm not going to talk about them here, but it's going to be very important, again, to pass your OSCE stations, so that you know that these causes of each of them. So you might get hepatomegaly without splenomegaly, or you might get both. And not everything causes both. Okay, So you've palpated your spleen and your kidneys, your spleen and your liver. So you move to the kidneys, and here you're going to ballot the kidneys. So I think the real point here is that just see how medially is actually. You're not going to put so you put your right hand at the top of the abdomen and the left hand just below at the flank. And the point is you're going to push down here, and then you're going to try and push the kidneys up to hit this hand. Okay, it's very, very difficult to really know what a ballotable kidney feels like. So what I would suggest is try and find a patient with polycystic kidney disease, and they will then, when you find that patient, just try and ballot the kidneys, because they're obviously ballotable kidneys, and just so that you know what it feels like. It's very difficult to explain, but just make sure that you're medial enough, because the kidneys aren't actually at the edge. They're going to be a bit more medial than you expect. So just see where he is at the moment with his hands, and then you just push down at the top, and then you're going to just try and make the kidneys hit this hand, basically. Okay, great. So just a quick thing. So obviously, if you have splenomegaly and you're wondering whether or not this could be kidneys, because actually it can be quite confusing sometimes, things that can help you know whether it's the spleen or the kidneys, whether or not you can get your hand above it. If you can, it's likely to be a kidney, because you're not going to get your hand over the spleen. The kidney is ballotable, as we just talked about. The spleen is not. The spleen has a notch. It moves on inspiration, and it's dull to percussion. So there's that, and these are actually these points are possible questions or viva questions that they may ask you at the end of your OSCE. So it's worth knowing these points. So next, so you've done the kidney, so you've palpated liver, spleen, and kidneys. Next, you're going to do the abdominal aorta. So you're going to palpate just between the epigastrium and the umbilicus, and that's because the umbilicus is where the aorta bifurcates. So you want to go above that. And here you're just going to palpate as you see here. You're checking to see whether it's pulsatile, but also you want to see if it's expansile. So it's not supposed to be expansile. If it is, then you're going to be worried about an aneurysm then. And you do get abdominal aneurysm, aortic aneurysms in your examination. So definitely try and feel as many abdominal aortas as you can, but don't forget to do that, because that actually might be the diagnosis in your OSCE station. Okay, so next we're going to percussion, and I've just emphasized that you need to practice, practice, practice. So when I was in med school, what I used to do was I'd palpate anything I could palpate. So I'd palpate the wall just to kind of feel the difference. I'll palpate a table, and just give me an idea of what things should feel like, what they should sound like, what a hollow sound is like, what a dull sound is like. And then once you're a bit comfortable, then you can then practice obviously with the patients and try and palpate normal abdomens, palpate tympanic abdomens, palpate abdomens full of fluid, everything that you can, just palpate, and then you just get really natural with it. And it's just because it's so important in almost all the exams that you're going to do. So just keep practicing. Great. So once you've palpated the liver, spleen, kidneys, aorta, then you percuss. So the aim of percussion is to just figure out exactly where the liver lies. So you're going to percuss from the right iliac fossa up to the point where you feel dullness. And then you're going to start again from the mid-clavicular point from here, down here. And when you get from resonance to dullness, you can then measure, usually with your finger breath, to see exactly how many finger breaths you can get to determine the size of the liver. And I guess what's really useful is if you do actually get hepatomegaly, you can say, okay, this patient has 3 finger breaths of, that's not how you spell that, apologies, of the liver, emphasizing that there's some hepatomegaly. So your normal liver size is 12 to 15 centimeters. So this is just another way to just figure out exactly what the size approximately is of the liver and whether there's any evidence of any hepatomegaly. Because obviously if you get any dullness beyond this point, it would indicate that there's some hepatomegaly. And then you're going to do the same thing for the spleen. Again, you're going to start from the right iliac fossa diagonally to the left hypochondrium, again, checking for any dullness as we discussed. So next, we're going to check for shifting dullness. So shifting dullness is a technique used to assess for possible fluid in the abdomen. And this all stems from the fact that if a patient is lying down at 90 degrees, you expect that the bowel, if there's some fluid, you expect that the bowel would be at the top, just at the umbilicus. And obviously bowel is going to be full of air, so it's going to be tympanic when you palpate, so when you percuss. So by starting from the midline, the patient should have a resonant sound when you percuss. And then you move across to the flanks, and you should get some dullness if there's any fluid, okay? The reason you have dullness is because when you're lying down at 90 degrees, the fluid should hopefully just, it should with gravity fall to the sides. So by moving from resonance to dullness, you're moving from bowel to fluid, okay? So when you do that, you tell the patient to roll towards you. And when they roll towards you, they're going to be lying on their side. At this point, the fluid should hopefully then move down to the other side. You wait for 15 seconds and then you tap again. When you tap again, it should be resonant. And why is it resonant? Because the fluid that was there should, with gravity, when you roll them towards you, fall to the other side. Okay, so it will go from the left flank to the right flank. Okay, I hope that makes sense. And then you roll them back. So really, it's just about moving. Basically, you're moving a patient's fluid from the left to the right side, and you're just checking at the end that the fluid is all gone and it's now resonant. Okay, so they estimate that if you can tell a patient's got fluid by shifting dullness, they probably have about 1.5 liters in the abdomen. So then we move on to auscultation. So you want to check for bowel sounds. So I usually check at the right of the umbilicus. It's important, of course. And then you want to check for renal artery bruits. And sorry, 2 seconds. It's really loud, do you mind? So you want to check for renal artery bruits. This is important because you can get patients with renal artery stenosis. So you auscultate anteriorly, obviously in the abdomen, moving 4 centimeters from the umbilicus, and you're listening for any bruits that would indicate that there's stenosis or renal artery stenosis. Then I would move on to the legs. So legs are important with every examination. I don't think I've examined a patient in a long time without looking at their legs. I just think it's a very useful exam in general. So you want to look for peripheral edema. If it's unilateral, obviously you're thinking about venous or lymphatic obstruction, but bilateral is probably what you're going to see in a patient in your OSCEs. So it could indicate heart failure, renal failure, hypoalbuminemia, or nephrotic syndrome. So obviously you get low albumin with patients with chronic liver disease or with IBD or anyone who's really unwell. Nephrotic syndrome is important, especially with a patient with renal failure, as it could be a possible cause. Or it could just be, again, like I said, heart failure. So just because you have peripheral edema doesn't necessarily mean that it's going to be a GI cause, but it would, of course, add to your differential diagnosis as well. Other things that you might look for would include erythema nodosum, pyoderma gangrenosum, which you might see again in inflammatory bowel disease. So then at this point, I would thank the patient and then I would cover them up. So please don't forget that it just looks really bad if we just leave the patient there and just start talking. So then you want to complete your examination. I will talk a bit more about presentation, but so things that you might do in a GI case, because it's always good to kind of learn just 3 or 4 things that you would want to say. So at the end of the examination, I would like to examine the hernial orifices, external genitalia, perform a digital rectal exam, or then, sorry, urine dipstick is not an examination. Remove that, that's an investigation. But yeah, so these 3 things are good things that you can just kind of reel off, and they usually work. Obviously, this rules out any abdominal masses, and this is really useful in patients with chronic liver disease, as they get quite edematous genitalia actually. And then DRE obviously is great with anyone with anemia or with chronic liver disease as well, ruling out any GI bleeds. Okay, so this is just an example of what you could say. I think it's really good to kind of have just a quick, some something that you've learned off for each exam, and it just helps you to read it off. This is quite long, actually, and the chances that you'll get a patient with this is obviously, well, it could happen, actually. So you could just say, I've just performed an abdominal examination on Mr. So-and-so. On examination, he was comfortable at rest with evidence of cachexia. There's evidence of leukonychia and palmar erythema on his hands, with multiple spider nevi present on his chest. On examination of his abdomen, there was hepatosplenomegaly and ascites, but also peripheral edema. This patient has, so I've written here, this patient has evidence of liver cirrhosis with portal hypertension. If you're brave enough to say that, I think it's good to be brave. If it all adds up and it makes sense, it's actually really good to just go for it. And it's very, and just shows that you're a bit more confident with your answer. So I would say the most common etiology is alcoholic liver disease, but other possible causes would be viral hepatitis B and C or non-alcoholic fatty liver disease. So I would like to complete my examination by examining, like we talked about, the hernial orifices, external genitalia, and perform the DRE. To further investigate, I would perform bedside tests, including a set of vital signs and a urine dipstick. I would like to perform blood tests, such as, again, depending on what case you have, football count, renal profile, coagulation, liver function tests, renal profile, and then imaging, such as an ultrasound or a chest X-ray, if you feel like they might be overloaded, etc. So you would then, so you need to kind of know what kind of tests that you would want for each patient, depending on the scenario that you have. So things that I would want to mention in my presentation. So I'd want to mention the positive signs or any relevant negatives. So you might say in a patient who's got abdominal distension, for example, there's no evidence of any peripheral stigmata of liver disease, or a patient who's got a liver transplant scar as well. It's just important to mention that. Or with a patient who's got a renal transplant, it would be really good to say there's no evidence of any peripheral edema, because that would indicate that the patient's transplant is probably working. Positive signs that you would also mention would include, again, like we said, peripheral stigmata of whatever disease that they may have. Then I would then talk about my possible diagnosis based on the signs that I've put together, and the likely etiology of the diagnosis, as we've talked about. It will be useful to have alternative differential diagnosis if you're not sure, or even just to broaden your horizons, just in case you are wrong, which is fair. And then how you would complete the investigation and further investigations that you would, complete examination, sorry, and further investigations that you would perform. So I'm just going to talk a little bit from liver disease point of view, things that you want to know about. So signs of portal hypertension, splenomegaly, caput medusa, esophageal varices on endoscopy and ascites. Obviously 1, 2, and 3 are the ones that you're going to see on your GI examination. You can have an enlarged liver with signs of chronic liver disease, but don't forget that a malignancy can be a cause of enlarged liver as well. So definitely put that in your differential diagnosis. When you've got a patient with chronic liver disease, it's really good to kind of look for an underlying cause. So things that might help you would be the age of the patient, their gender. You might have a patient with evidence of diabetes, so you might think hemochromatosis, xanthelasma, so you might think of more autoimmune conditions. Like we said, case of Fletcher rings, so you might think Wilson. So just try and not just say this patient has chronic liver disease, try and figure out why they have chronic liver disease, and then also know whether or not the patient is compensated or decompensated. So that just means that usually when you've got liver injury, your body still can function up to a point. And then when you start getting ascites, when you start getting jaundice or complications, then they become decompensated. So many things can actually cause decompensation. And it's actually really important to know what can cause decompensation, even clinically, because when a patient presents to you decompensated, so they've got hepatic encephalopathy, they've got ascites, it's really important to know why they're decompensated. So things that might cause that include infection, deranged electrolytes, increased salt intake, or even a GI bleed. So when these patients present to you to a hospital or something, it's really important to actually investigate and figure out what's knocked them off from compensated to decompensated. So that's a really important thing to know. So these are possible viva questions that you might get with liver disease. There's a lot of them. So I just think it's important for you to walk into that exam and know the answers to these questions, because they always ask them. So causes of chronic liver disease, complications such as SBP, GI bleed, spontaneous bacterial peritonitis, that's SBP. So they'll ask you about ascites. How do you investigate ascites, causes of ascites, what does decompensated mean? Like we said, what causes decompensation? How do you grade the severity of your chronic liver disease patients? So the child's Pew score. How do you classify causes of jaundice, pre-hepatic, hepatic, post-hepatic? Again, like we said, causes of hepatomegaly, splenomegaly, and gynecomastia. How do you manage patients with chronic liver disease? So when they have a transjugular intrahepatic portal systemic shunt or a TIPS, it's really important to know what that is. You can talk about hepatitis C treatment. Just know that there is a treatment for hepatitis C now, which actually completely treats a patient. And also just what liver transplant is, what it looks like, what are the complications, and how we manage patients with liver transplants. So renal disease is similar. So you want to know the major causes of end-stage renal failure. How do we perform renal, what are the modes of renal replacement therapy that we talked about? And what are their complications of each and every one of them? So whether or not they've got AV fistula, whether or not they've got a tunneled line in, or whether they've got a peritoneal dialysis catheter. What are the indications for renal replacement therapy in a patient? So things like hyperkalemia, fluid overload, uremic pericarditis, metabolic acidosis. What's the etiology of this patient's renal failure? So it's really, that's actually similar to the first question, but yeah, it's good to know what causes renal failure. So type 1 diabetes, hypertension, glomerulonephritis. What are the complications of post-transplant immunosuppression? So it's really important to know what the complications of each drug is. So first of all, you need to know what immunosuppressants that we use. So these include steroids, cephalosporin, tacrolimus. So each of these drugs will then, or sometimes they use MMF as well. So each drug will have its own complications, and it's really important to then know the drugs and the complications. And some of these complications can be signs in your examination. So they can be actually relevant negative. So if you have a patient with renal transplant, you can mention that I didn't see any tremors on examination. We could indicate tacrolimus toxicity. There was no gum hypertrophy, which you can see in cyclosporin. So it just helps to put the general picture in together. And then, like we talked about, the difference between a kidney and spleen on examination. Okay, and then possible questions you can get in a transplant case. So the likely etiology of the disease. So don't just say, like I said, this patient's got liver transplant. What could be the cause? So it's really good to know the number one cause of a patient with a transplant. So I think here in the UK, it's diabetes actually. And then if the patient's got a transplant and it's a renal transplant, you want to see what evidence there is of renal replacement therapy at the moment. So like I said, if the patient's got an AV fistula that's working, it tells you this patient's graft isn't functioning. Hence they need renal replacement therapy. Okay, even though they've got a transplant, it's not working. What current immunosuppressives are they on, and what complications, like we said. So things that you might see in an IBD case, so viva questions they might ask, ulcerative colitis versus chronic disease, true loves and widths criteria, how do we manage IBD, and what are the extraintestinal manifestations of IBD? I have highlighted that because they love this question, and it's really important to know. So you divide that into manifestations in the eyes, musculoskeletal, in the legs, like erythema nodosum, like we talked about, and yeah, and you just have to kind of learn them as you go along. So the tips that I would say helped me would be to practice. So I practiced, again, every part of the exam that made me uncomfortable. For some reason, percussion just took me a while to get. So I just ended up percussing everything, like I said. You have to be very systematic, and you just do the same thing over and over and over and over again, so that on the day when you do get there, you'll just automatically do the examination. And then because you're on automatic pilot, you can then focus on what's abnormal. Learn common presentations and likely questions like we talked about. Keep an open mind, especially in a GI exam. Don't just assume just because that's a scar, it must be this. You never really know. There's so many ways it can present. So just keep an open mind, because what you think you'll get, you probably walk in there thinking you're going to get a nice, lovely patient with ulcerative colitis who's got a nice ileostomy, and then you walk in there and you get, anything. And I think that's the beauty of the abdominal examination. They can literally give you anything. Understand the kind of cases your hospital will have. So that's just really it's just a tip. If you're in a renal transplant center, just see all the patients with renal transplant. You can't leave that hospital without being amazing at renal transplants. Same if you work, say, for example, in King's, if that's your local hospital, just go to the ward, sit there, learn, know your liver patients, feel every liver patient, go to the ward rounds, learn about the complications and things that you see a day 1, day 2, day 3 post liver transplant patient. Look at the drains, look at the size, look at how they place them, look at a patient who's just had an acidic drain. What does the drain look like? What does the scar look like? Things like that. And then stay calm. Again, just because one station doesn't go as well as you want it to be, try to just stay calm. It's easier said than done, but it's just something that helps, of course. So this, I'm just going to go through 2 cases, which just I want to use to emphasize the importance of picking up the signs, but not only picking up the signs, but putting them all together to hopefully come up with a diagnosis. So this was a lady that I had. So it was a 25-year-old, presents to you with hypertension. Please perform an abdominal examination. And I thought, ugh, hypertension, fine. I was thinking chronic, oh, she must have chronic renal disease. I'm going to see a fistula. It's going to be great. It's going to be amazing. So I looked at her. She was young. She looked well. And then I didn't really see anything except she had these on her back. And I thought, okay, this isn't really what I wanted, but fine, I'll go with this. And then she had one of these. So I don't know, I can give you maybe a few minutes, you're going to put it in the chat. What do you think would put this all together? And why would she have hypertension? So this is a 25-year-old, and you find that she's got this on her back and that. Oh, you have put comments, excellent. Yes, okay, so great, so exactly. And why does she have hypertension? So that's the thing, isn't it? It's not, so you've got the diagnosis, so you've got to put it together then and figure out why she's got hypertension. Renal malignancy. Not quite. What would cause? Yes, we've got fail, yes. Anything else? They love saying that in the vibers, by the way. Anything else? And then you panic. But yes, that's what they said to me. Anything else? So failure is correct, yeah. So just to help you out, so you can also get renal artery stenosis as well. And then apparently you can get coarctation of the aorta. So that was the case I got. And I think it was the only thing that I had obviously to put together, and you just have to be brave enough to just go for it. And also it was really important because she only had one cafe au lait spot, and if I hadn't looked carefully I would easily have missed it. And she didn't have this many neurofibromas. She only had about 4 or 5, so it was very subtle, but it's just an example of what they might throw at you. Okay, so this is another case that I saw. This wasn't even my case, so ignore that little thing. So it was a 45-year-old woman presenting with pyrexia. Please perform an abdominal examination. So she walks in, she's 45, and she's got one of these. And I was like, that's interesting. Why does a 45-year-old woman have, why is a 45-year-old woman needing mobility aids? What do you think? Why would a 45-year-old woman in an abdominal examination need mobility aids? Okay, I'll give you an additional hint. She also had this in her hands. Okay, does that help? Yeah, excellent. So it was really just diabetes, but then she had this as well. Okay, so now put that all together. So she's got diabetes, we know that. And then she's got these scars on her abdomen. Okay, first of all, I guess what would this scar indicate? Yes, okay, so she's got, someone said renal transplant, excellent, okay. But why is the diabetes important? Yes, okay, but what else? I guess there's something else that takes it takes it up a notch. So it's a renal transplant, definitely. But what else can you get with renal? What other transplants do they do with patients who've got diabetes alongside the renal transplants? Yes, pancreas, exactly. Okay, so do you think her pancreas is working at the moment? Excellent. Why do you think it's not working? Okay, so she had so basically the hint, I guess, is here. Why would a lady who's got a pancreas transplant still require these finger prick tests? It means that her pancreas is failing. So she's a lady with a renal transplant and a pancreas transplant, but her pancreas is failing. And I suppose the whole point of that case really is to just let you know that you can find out what you can basically you can do levels to how well you can do in the OSCE. So you can say what you see, or you can put it all together and come up with something epic. And I think not everyone actually got that. And it was a little bit of a subtle case, but just to emphasize the importance of putting everything together. And, you know, it might seem wild sometimes, but sometimes it's just worth just going up on the limb and saying, no, I put this together and I think this is what this lady has. Okay. So that's it for now. Does anyone have any questions? I feel like that was quite a quick one. So please, if you have any questions, I would be happy to answer them. But if not, there